Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. It is Friday, March 16th. This week we cover big announcements from HIMSS. This podcast is brought to you by Health Lyrics, a leader in moving healthcare to the cloud. This is episode number 10. My name is Bill Russell, recovering healthcare CIO, writer, and consultant with the previously mentioned Health Lyrics. In 2011, I became the CIO for a pretty large health system, $5 billion, 16 hospital system in Southern California. I immediately realized that I needed some people with wisdom, some people to help me chart the course. And so I asked around, and people recommended I seek out the two Johns from Boston, Glasser and Halamka. And lo and behold, the two Johns were teaching a course at the Harvard School of Public Health called Leadership Strategies for IT and Healthcare. And it would have been a great course if it was just the two of them, but they also introduced us to some great people. Stephanie Reel from Johns Hopkins, Blackford Middleton, Dr. Tejal Gandhi gave a phenomenal presentation on the value of the EMR. On that week, I was introduced to Ken Mandel as well, who helped shape my thinking around EHR interoperability. It really was a wonderful experience. Today, I'm joined by one of the professors of that course and one of the Johns, CIO of Beth Israel Deaconess, Dr. John Halamka. Good morning, John. Welcome to the show.
Good morning, and what an honor it is. You know, as a 55-year-old person, my next 30 years are devoted to mentoring those who will replace me. So it's all about the students.
Are you still doing that course? That was a phenomenal course.
Yeah, and so although it has been shaped and shifted a bit, because remember that course came out of the meaningful use era, and now we're in the kind of post-meaningful use era. So, you know, professors and topics are slightly different, but I'm absolutely in it every year.
Well, that's great. So I'm going to give a brief, your bio is way too long to read on a 30-minute show. So two-time CIO of the year. The Harvard website lists like about 65 publications that you've been a part of. I'm sure it's larger than that. It actually looks from that website like you either retired in 2011 or they stopped updating it after 2011. But I love on that site that it lists your 1980 National Merit Scholarship. So they really captured all the things that you've accomplished. And clearly, you're a prolific blogger under the Geek Doctor on Blogspot. Life as a Healthcare CIO. You also have a book by the same title. And so I'm wondering, the blog, are you gonna change the blog to, I don't know, Geek Farmer, or what's any changes in store for the blog?
Well, so fascinating question. Have you noticed that in 2018, the attention span of most folks seems to be reduced a bit?
Yeah,
so,
that's why it's a 30-minute podcast.
Yeah, so in fact, I've written thousands of blog posts and articles, but what I've figured out is that people these days want tweets. They want Facebook, they want Snapchat, they want Instagram. So what you'll see is that although I'm still writing for the academic literature and writing books and articles and opinion pieces and that sort of thing, my social media presence has actually been reduced to sort of daily, here's a pithy thing you should learn about today.
Yeah.
And so a little different.
Yeah, it is a little different. Well, one of the things we like to do before we get into the meat of the show is just ask our guests, what's one thing you're working on now, or what are you excited that you're working on right now?
So you may know that I served Bush for 4 years, Obama for 6 years, and the current president not so much. And so I'm spending much of my time internationally. And so the Bill and Melinda Gates Foundation asked if I would help unify the data of Africa. And how do you deal with HIV, malaria, and TB? How do you deal with challenges of a mobile workforce? People whose names, genders, dates of births are probably not sufficient or accurate for matching. So my current work, which is really interesting, is deploying biometrics in Africa in a cloud-based, blockchain-backed mechanism to exchange healthcare data for HIV care. So it's live in South Africa today. Next step, we'll be expanding to Senegal and Mozambique. Yeah,
you shared that in the patient ID section, and it's actually it's amazing because generally speaking, I mean it's better than what we have in the U.S. I think. I mean, you're matching the patient data. You're bringing that stuff together and bringing that data to the point of care, which is something that we still politically and for other reasons still struggle with in the U.S. It's pretty amazing.
But remember, in the U.S., we have extraordinary technology in medicine, but we have what I'll call psychology problems, right? That is, there isn't an incentive to share data. Or maybe as CIOs, and see, you had no gray hair before you became the CIO. We're also stressed that we have to be so focused on, I don't know, email reliability as opposed to interoperability. It just hasn't floated to the top of our priority at the moment.
Yeah, that makes sense. Well, here's what we're going to use as our framework for this discussion this week. We have, I just pulled the Modern Healthcare Story. It listed 7 announcements. I'll read off the 7, but if you have another one or that you want to highlight, that's fine. Here's the 7 that they sort of highlighted. Big announcements from HIMSS. Google announces Google Cloud Healthcare API. CMS, Seema Verma announced Trump administration's My Healthy Data initiative, which includes MU changes, and we'll definitely talk somewhat about that. Cerner will add Salesforce, their Health Cloud, and Marketing Cloud to Healthy Intent. Validic launched Validic Impact. United Healthcare is bringing Apple Watch to its motion wellness program. CMS to push Blue Button 2.0 API for 53 million Medicare patients. And Epic has integrated Nuance's AI-powered virtual assistants into its EHR. And these were just the top 7. As you know, everyone sort of stores up their big announcements for that week, and there's probably 100 others. So here's what I'd like to do. So what we're going to do is I'll pick 2, you pick 2, and I'll kick us off here. And I'm going to cheat as I usually do. This is why I do a show, so I can cheat. I'm not really going to focus it for my first thing. I'm not going to focus in on one specific item. I'm going to focus in on a trend that I'm seeing that's going on, which is this move to the cloud. Because if you look at the Epic Nuance, that's AI powered. That's a move to the cloud. You have the Salesforce Health Cloud. That's a move to the cloud. You have Google's API, and you did a session on cloud at the Chime event. And so I think it's kind of timely, kind of interesting to talk about. And I'll sort of sum it up this way. Eric Schmidt did the opening keynote, and here's a quote that I pulled out of there. So he said, "Get to the cloud, run to the cloud immediately. I can assure you that our data centers are more HIPAA compliant, more secure, more efficient, and better than your data center. Only after you get there will you have access to a host of new capabilities." And he went on to talk about access, that you're not going to build out these AI and machine learning capabilities in your data center, that you're going to want to tap into the things at scale that the cloud brings. Also, Jonathan Bush did an interview. Jonathan Bush from Athena went on to talk about another trend, which is people want to they want to develop directly into these applications, and we need new architecture in order to do that. And he said, I went from, we have a lot of other tech companies connect to AthenaNet to the base where we are now, to you've got to actually let other people build in AthenaNet. So, the basic premise that I have is cloud started off as an infrastructure play. So let's get out of our data centers and let's do DR in the cloud. Let's go to Amazon Web Services, those kind of things. Then it moved to more of an application deployment model. Some of us did Workday, some of us did Box, some of us did Salesforce, and the myriad of other, and EHRs are now trying to do deployment models through the cloud. And now it's really changing to an architecture play. The platforms are allowing us to create new types of applications. And in healthcare, there's thousands of applications that still don't live on top of these new models, and therefore they're not open. It's harder to share data. It's harder to do some things. So, let's just start with, my question for you is, have we finally moved beyond the fad stage of the cloud, or are we moving to, this is now something that healthcare CIOs should definitely have a strategy for and be moving forward in, I don't know, a little bit more of an intentional way?
Well, so I think you've summarized the trends at HIMSS extraordinarily well, which is, move to the cloud, embrace open APIs, have a suite of apps that surround your transactional systems, and truly engage patients and providers in novel ways. While all along while adopting machine learning, AI, these newer technologies while keeping everything reliable and secure. But so let's ask, where's the cloud great? Where's it not? So as a CIO, I oversee 145 mission critical applications deployed to 40,000 users, accessed 12,000 times a second at 450 locations of care. You know, I'm living the dream like you did. Now ask yourself, how exciting is it to wake up in the morning and wonder whether your VMware slices are booting or not? It's like not in 2018 interesting.
Right.
I need to focus my day on how do I improve the doctor usability experience? How do I make that sort of patient stickiness to our healthcare system as opposed to the competitor's healthcare system better? And if you look at sort of traditional architectures, let's take us, you know, because you and I are probably a similar age. It's 1995. It's Fox Pro or Fox Base. You know, it's 2 to 3 tier client server. It's like you can't move that to the cloud. Right? You need to have an architecture that says you're web and mobile native, you've got APIs, and you've got this transactional system running in a place that's very easy to connect to. So for me, I've moved 7 petabytes of patient-identified data to AWS. I've moved my production clinical systems where I can, right? That Fox Pro thing still can't move, where I can, to the cloud. And sure, I've kept some on-prem because, you know, the internet might disappear. I mean, it's not a joke, right? I mean, you're going to get North Korea or God only knows what state-sponsored cyber terrorist activity to take out, I don't know, DNS routing or something, right? So you got to have some things local. But I really, really try to move things out of my data centers because I want to procure rather than provision services.
Right.
And what you saw at HIMSS 2018 is exactly what you mentioned, which is people say, oh, actually, this is not a risk. It's a risk mitigation because Amazon has 50,000 employees instead of your 5, you know, looking at security. When badness happens at the internet, you think Amazon is going to route first or you? It's going to be Amazon that figures out a route around the problem.
Right.
So we're doing it. The BAAs are sufficient. The reliability is sufficient. But there's one area that's not sufficient, and that is indemnification. So for fun, go call Jeff Bezos and say, hey, Jeff, you know, let's imagine a bunch of Amazon engineers go rogue. And suddenly, you know, I don't know, the HIV status of government officials is on Facebook. Are you going to indemnify us against that? His answer will be, no.
Yeah.
Right. So you've got a BAA, that's great. And you've got highly reliable, highly secure infrastructure. But I'll tell you, it's just still early. Google, Amazon, NTT Data, all of them aren't quite yet to what I'm going to call a single standard for paying you should badness happen to your data.
Right. And that's, I'm not sure that's going to change. We did have Workday, we did have Box, we did have Salesforce, Microsoft as well, and we have BAs with all of them. And when it came down to the indemnification clauses, there's not a single one of them that would sign up for it. And I don't foresee that changing anytime soon. Do you?
Well, I imagine there's sort of 2 models to explore, which is I have a $25 million cyber liability policy from Lloyd's of London.
Yeah.
So I say, Amazon, Google, NTT Data, Microsoft, here's my data. Oh, and by the way, I will protect around that with a cyber liability policy. But Michael Dell, back when Dell was doing hosting, an actually interesting thought. Said, you know, I can't make it an infinite indemnification, right? That would bankrupt the company.
Right.
Well, how about this? I'll agree to pay you 3 times, triple damages, you know, over what your contract value is. So you invest $1 million with me, I have a $3 million check headed your way if anything bad happens. Now, obviously, that's not exactly sufficient. If I have, I don't know, 2 million patients in that cloud, and the, say, average cost when you consider litigation, media management, credit reporting, forensics, all the rest, is $300 per patient. You know, 3 million doesn't go very far.
Right. You know, one of the things you talked about Fox Pro, and we're both programmers, probably at a different level. I mean, you programmed an EMR, and I used to make applications within Fox Pro. The thing we loved about it is highly, I mean, you could customize the heck out of it. You could make it do exactly what you wanted to. I think this is one of the drivers to the cloud now. Even though they are very, you know, when you get Salesforce, you get Salesforce out of the box, but then you have this Force platform on top of it. And now all of a sudden you can build applications that you can really customize the solution. You can bring in IoT data. You can do a whole bunch of things to it. I think this is one of the new drivers to the cloud that that we're seeing is this, you know, and I guess Jonathan Bush also talked about this, that people want to be able to plug in new applications, new thoughts, new things into it. And the cloud is giving us a new way to do that we haven't really had since FoxPro, to be honest. I mean, people give you the EMR and they're like, here it is. You know, if you want something, put in a request and maybe the vendor will do it, maybe they won't do it. So
Right.
what are your thoughts on that?
Totally correct. So we call this at BIDMC the EHR plus strategy. And what does that mean? So it turns out I have 5 clouds of EHRs, right? So I got an Athena cloud, got an eClinicalWorks cloud, a Meditech cloud, an Epic cloud, some self-built clouds. But they're all FHIR enabled, right? So what we say to this, 26-year-old in the garage, you know, you have this beautiful function that doesn't exist in the EHR. And what if we get input data from the transactional system using a JavaScript object notation from the cloud? Can you plumb that? And the usual answer is in a weekend, right? You know, it's like, oh, here's a new OR productivity application. Is Monday good enough for you? And that's literally what we're seeing. As long as you cloud enable your data and your transactional applications with standard Argonaut-based specifications on FHIR, that ecosystem of app developers can just rapidly deploy what you need.
That's great. Well, we spent a lot of time on cloud. I'd love to hear what your first big announcement you want to talk about.
I know this is going to sound like the Gartner hype curve, right? But I thought the theme of HIMSS in 2018 was machine learning, right? And you have to be careful. What is machine learning? It's not, Watson is going to replace doctors. I mean, that's not what we're talking about. We're talking about boring, prosaic stuff. And let me give you an example of what I went live with yesterday. Now, I hope you've never had to have surgery, but if you've ever had surgery, you know the doctor can't put a knife in you without a consent. You were a CIO, you know what a nightmare it is to track down thousands of pieces of paper coming from doctors' offices all over humanity with a handwritten wet signature on consent.
Right.
And so fine, you digitize this or that and you have e-consent, it's just still a nightmare. So what do? We asked Amazon to monitor our fax machines. Now, what's that all about? We trained Amazon machine learning services to recognize consent forms. And so what happens, this is literally the application. Amazon is a listener on our fax traffic, and when it sees a consent form, it knows how to identify the patient on the consent form, and then writes via a FHIR API a checkbox into the EHR that says consent received. That's all it does. So, wow, suddenly no armies of humans searching stacks of paper, and Amazon just does it for us with 99.9% sensitivity and positive predictive value.
Wow, did that require you to move your data out, or is this just, I mean, you could have done that without moving your petabytes of data out to AWS?
And the answer is it just turned out to be a little easier to plumb because I have my EHR in AWS. So, right, connecting an Amazon machine learning service to an app that's running in AWS is like minutes, right? You don't need to worry about, there's no firewalls or VPNs or any of that other crazy stuff, but you're correct. As long as you move to this sort of API approach, it could have been possible for Amazon's app to call an API even at a distant site.
That's interesting. So, last week I said that, some of the overhyped themes were AI, machine learning, were some of the things. You walked into a booth and they said, we're using AI, we're using machine learning. Of course, if you ask them to distinguish between machine learning and AI, they really couldn't do it. It's just, well, it also is indicative of who's working the booth floor versus whatever. But these technologies are real. We saw, I count like about 15 to 20 real world examples. The 3M booth was interesting. They have real world examples where they have applied these things because of the new, the ability to move things through the APIs, the ability to free this data, and now the computing power that's available. It really is only limited by our creativity to start thinking about what things that are very manual today that we could then automate by, you know, plugging these things in or other tools that are out there. And the great thing about the cloud is that you literally could fire it up this afternoon with a credit card.
And you're totally right. So when I talk about the machine learning applications we've deployed, they're literally like written in a weekend. And so here's another example. I built an API into our OR scheduling system, and I now have access to millions of previous OR cases, doctors and patients. I don't use the names, that's not important, but the patients say, what is the procedure or what is the comorbidity? So what if you say, hey, Amazon, Bill needs an appendectomy. How much time should we allocate? Well, oh, Bill is a 53-year-old person with no comorbidities, and the surgeon is Dr. Famous, who's done 1 million appendectomies. The answer is 25 minutes. So we just did that. And what did it do? It freed up 30% of our OR schedule.
So here's the question. So we have, you know, CIOs from across the board. So you'll have a CIO from a rural health system. You have a CIO from a multi-billion-dollar large health system with a $100 million budget. No, this used to be something that only the $100 million budget CIO could really talk about. If you were the CIO of a small rural health system, are there things you could start thinking about and tapping into that you couldn't do before because this stuff is available?
Right, and so we're an open source shop, so to speak, and that is everything we do, we open source to the world. So you can assume, you know, fine, we might prototype something for you, but then it's going to be available at Google or Amazon or other provider to just lift off the shelf with your credit card for, you know, $49.95. So I guess the one advice would be, make sure your EHR vendor provides these FHIR APIs. You know, move to cloud hosting if you can, and then you can just take advantage of this library of all this other stuff. And just one final example for you. Beth Israel Deaconess is going through a merger right now. $5 billion merger, because healthcare gets better by getting bigger. Remember that. And our philosophy is, even though you're going to be running Epic here or Meditech there, these apps will run anywhere, right? And so just lift them off the shelf, plug them in, done.
All right, sorry, I had a technical glitch there for a second on the sound. So you know what? Let's jump to your favorite topic. I know you've worked in a lot of different administrations, and this is not really a left-right issue on the political spectrum. This is really about interoperability. We want better care through interoperability, and I'm just pulling up the article from the magazine. So what I'm going to cover is some of the announcements from CMS and the administration. I think the thing we can agree on, the closing sentence here, is we can effectively transition, we cannot effectively transition to a value-based care system unless we transfer all of the clinical and payment data to the point of care. I know we can get better care if doctors have all the information. I'm not sure of that statement specifically, but common ground would be the more information you have at the point of care, the better care you're going to receive. And that's the promise of interoperability. So here's some of the announcements, and I'm curious, I'll just read some of them, and I'd love to get your feedback. So for data to flow freely, so this is a quote from Seema Verma, the CMS administrator. For data to flow freely, she said, there would have to be an overhaul of meaningful use, and the full ballroom at HIMSS 18 broke into applause. Does that surprise you that they broke into applause at all?
So meaningful use built a really important foundation.
Absolutely. I firmly believe healthcare still would not be digitized if we didn't do MU. So.
And stage one was great. I mean, Dave Blumenthal, John Glasser, and the team put together a good floor. It started to unwind and unravel at about stage two, where then what ended up happening, unfortunately, is that every federal government department decided to make meaningful use its policy lever. Oh, I think we should have implantable devices using universal device identifiers. We should record social determinants of health. We should stamp out Ebola. And every one of those was layered on top of MU. And so what ended up happening is it co-opted the agenda of every healthcare vendor and every provider in America. What should have happened is we should have had, I don't know, stage 1 and stage 1 plus, and then stopped. Yeah. And so what we're dealing with now when we talk about stage 3 is it's just not relevant, right? We're living in a world of machine learning and APIs and clouds, and it's still with, what are the 17 quality measures for diabetics you're going to collect? And it's like, oh, stop.
So instead of, so what they say is you're going to see a series of proposed rule changes by the end of the year. Should we just say it's had its day and end it, or should we try to modify it?
So here was my complaint with both stage 2 and stage 3. It in effect said you must drive a Prius. Well, wait a minute. I have a Volt. No, I have a Tesla. No. It has to be a Prius. Well, is the outcome that you should be able to drive a vehicle with low pollution? Well, then let me buy what I want to buy. If I want to use a skateboard, that's okay too. I'll get some exercise. And that's why we need to scrap the current meaningful use construct. And what we need to say is the outcome is that patients and families are going to have better engagement because we're building tools. But don't tell me what tools or how to build those tools, because in my case, believe it or not, I've built 30 Alexa skills. And so it's like you can have Alexa on your desk and say, make me an appointment with my cardiologist. As opposed to what an MU may say is build a portal and have a checkbox. Well, no. So I love this idea. And as you say, it's apolitical. It's not right, it's not left. I would say, let's have an outcome we want to achieve, and then let the market figure out how we might solve that best with emerging technology.
Yeah, I agree. I'm going to read a couple more things here. So continue to quote, we're changing to a new era of empowered consumers. I love the fact that we're finally using that consumer term. We can talk about that. So we're changing to a new era of empowered consumers. We are putting patients first and making sure patients have access to their healthcare data. You're hearing that from the White House as well. We're very clear that patients should have their data and access to it in a timely manner, because that will increase, this quote is silly at the end, but that will increase quality, duplication, and testing. Well, we don't want to increase duplication, so I'm sure it was whatever. Right. But generally the thought is, if we give it to the consumer, that is going to help to change healthcare. And one of the articles I wrote a while back is I had this theory that if you did give the patient data to the patient, if the patient had all of their data, and I love ePatient Dave, and I've had him speak at our health system. I think it would really change some things if I had all my data and every American had all of their data. I think you'd see a couple of ecosystems arise. You'd have cloud providers come in and say, hey, give us your data and we'll add value to it. You'd have researchers come in and say, hey, give us your data and feel good about yourself. You're going to help us to cure cancer. And you may even have pharma come in and say, hey, give us your data and we'll give you money. It's your data, it has value to us, and we want to compensate you for the value. Are we at a point now where there's enough momentum behind this, or are we still caught up, and you're a doctor as well, so are we still caught up in we don't want to give data to patients because they don't know what to do with it, which is, the Judy quote that I think she got caught on. But that's a sentiment that I found talking to a lot of physicians. I'm trying to protect the patients. If they had this medical record, they might make the wrong decision. Where are we at on this?
Sure. So I think you are absolutely right. The era of consumer empowerment is here, and any restrictions on data flows are gone. Where Judy got in trouble and where I've gotten in trouble, I'll just tell you, it's because the intent of what we're meaning is just telling a patient their serum sodium is 139 isn't very exciting.
I have no idea what you just said.
So. Right. As opposed to saying, I'm going to fluidly give you all your data, but I'm also going to help you navigate the healthcare system. which is here's how you make an appointment, and here's how you get a referral to a specialist, and oh, here's a machine learning plugin that's going to compare you to 10,000 people like you. I mean, those things of value that's really what we want to have, not just a portal where you can read your serum sodium. So absolutely. Beth Israel has been sharing notes with patients for 5 years. Everything about you includes you. And we just started an initiative where you are writing the note that goes back to the medical record. And so the doctor could say, oh, I think you're depressed. And you could say, no, I'm just, not energetic and it's rainy or whatever. You put in what you say, what you think as part of the medical record. So that's where we are.
Wow. So that is where we are. So let's see. They also announced My Healthy Data, and I don't know. Let's just for a second, and then I'll let you choose the last story, whatever you want to talk about. Everyone's throwing APIs around like it's the cure to everything that ever existed within healthcare, but we still have this data challenge, right? So my data at my health system is different than your data, and your data from one physician to another could be a challenge. How much are APIs actually going to solve, and how much do we still have a huge heavy lift with our data to clean it up and get it ready to be meaningful when we actually move it?
So you highlight a really important point. So if you read TEFCA, that Trusted Electronic Framework and Common Agreement, it says, oh, we're going to put APIs everywhere for everything. Well, no, right? APIs are fine if the use case is query response. I want to get my data from a doctor's office. Are APIs useful for saying, for the last 10 million patients like this, what was the morbidity and mortality? Like, no. So what we need going forward is APIs for certain architectures and use cases. CCDA, payload transmission for others. Bulk extracts and ETL for others, right? So pick your technology based on the use case and application, and then you'll be fine. APIs are very important because it does allow this ecosystem of apps to evolve, but it's only one part of the puzzle.
Right. Well, do you have another story you want to, or theme from HIMSS that you want to highlight?
Sure, and that is that the role of the CIO has changed totally, right? So back again, since you and I are of similar age, we were software developers and architects, and we could tell you what RAM to use based on its transactional speed. Do you think any of that matters anymore? The answer is no. What you need as a CIO in 2018 to be is a convener. You understand business requirements and strategy, and then you take that and procure services from multiple cloud providers and plumb it together. And so it's just so funny. I have an MIT engineering degree. I had to be a doctor, engineer, politician, economist to survive the 1990s. But today, unbelievably, you'd probably best be a sociologist.
Right.
It's all about people.
Yeah, the role has changed to how can you help the organization to navigate change? And that is helping people to understand the vision for, hey, here's what's possible, and then bringing them together to have a conversation of, okay, if these are all the things that are possible, what should we be doing? Should we be doing something different in the Boston market than they are doing in Southern California? Probably. I mean, our environments are very different and our communities are different, and there are things that are probably a priority here than aren't there, but we're people that lead those conversations. It's really fascinating to me. The other thing that's fascinating is I had a fair number of conversations at the Chime Forum, and a whole bunch of the CIOs have been pushed into this operational role, and then you've seen these other roles sort of elevate: chief digital officer, chief innovation officer, and I'm not sure the CIO, the chief information officer, knows what to do now, other than, okay, well, my job now is to keep the EMR running, to make sure the data center runs, to have DR capabilities, and even security somewhat. I mean, not the implementation, but the oversight of security has been taken away from them as well. And they're saying, okay, my job, they really have become more of a director of infrastructure and technology than a traditional CIO. I mean, what do you say to someone who's saying, I want to get out of that trap? How do I get out of that trap? And how do I don't know, differentiate myself in that space?
Right. So I became a CIO in 1996. And as a CIO, I was the chief digital officer, chief innovation officer, chief medical information officer, and the CISO. Right. And so what have I done over the last 22 years? I'm the air traffic controller,
Right.
but I have carved up the office of the CIO into 5 different components. I mean, the ones we just enumerated, because that's the nature of how the work has to be done these days. So fine, tell a CIO, you're a sociologist, it's a change management activity, and you're a convener, and you have these experts working for you at these individual domains. You can't do it all yourself. It takes a village.
It does take a village, and it is a larger job than any. And people should not be concerned that, hey, they just hired a chief innovation officer, and they just because they're very different roles. A chief innovation officer is working with VC and private equity and looking at deal flow and a couple other things. And as the CIO, that also has to overlook security and whatnot. You just cannot do it all. There's just no way anymore.
So absolutely true. And so these days I spend a lot of time, as I mentioned, internationally. So I'm working with entrepreneurs in Israel. I'm working with entrepreneurs in China. And so imagine the CIO who's worried about whether the EMR is fast or slow. And, oh, I've got this great new project in Wuhan. It's like, I can't pay attention to that. So that's why the innovation role has the freedom to explore these new things that are a little bit tangential to operations.
Yeah. All right. Well, here's we usually close out with your favorite social media post for the week. Do you happen to have one, or am I surprising you now?
Oh, well, you know what Harvard faculty say? The favorite post of the week written by me?
Sure. What do you got?
Right. And so you'll see a Twitter post in the next 2 minutes or so where I thought a very novel means of communication. I mean, this is going to sound so silly to you, but the Northeast has had a torrential winter. It's been horrible. I have to buy a new chainsaw. And so the guy at the chainsaw store emailed me a photo of a message on his Apple Watch saying when my chainsaw would arrive. Wow. It's like, we are now reduced to emailing pictures of Apple Watches to each other. Who would have thought?
Oh man, that is a sign of the times. My post is a little more traditional. I guess I'll have to quote my own going forward. I didn't think that was a possibility. I thought it was interesting. There was HIMSS had a very lively Twitter feed during the event. They had a couple of polls. This one was, what will the biggest impact to newcomers like Amazon, Google, Salesforce, and Apple and other traditional technology players entering healthcare? What will the impact be? And it had 4 options: spur innovation, increase confusion, grow vendor consolidation, and improve user experience. And looks like we're split. I mean, it's pretty, spur innovation, sure, 30%. Increase confusion, sure, 20 some odd percent. Improve user experience, sure, 30 some odd percent. The answer is we don't know. There's been so many missteps, and we're gonna see as everybody else sees. So, John, thanks for being on the show. That's really all for now. Please follow John on Twitter at @Halamka. And his blog, Geek Doctor, or geekdoctor.blogspot.com. Wow, you stayed with Blogspot a long time. That's been a pretty good platform for you.
So far, so good.
Yeah, that's great. So you can follow me at Twitter at the Patient CIO. My writing on the Health Air's website and Health System CIO. Every other week I get an article out there. And don't forget to follow the show on This Week in HIT. And check out our new website, thisweekinhealthit.com. And if you like the show, please take a few seconds and give us a review on iTunes or Google Play. And if you don't like the show, please send me an email. Tell me what you'd like to see us do. So please come back every Friday for more news, commentary from industry influencers. That's all for now.